So for those of y'all who don't know me, I'm Dr. Callegan-Poche. I'm an assistant professor in internal medicine and pediatrics and the associate program director for our internal medicine and pediatrics residency program. I went to med school here, did my med peds residency here, and then stayed on as an attending this year. So today I'm going to do my grand rounds on Do Ask, Do Tell, treating LGBTQ plus children and adolescents in the primary care setting. So I can't take credit for the Do Ask, Do Tell. It's actually part of the National LGBT Health Education Center's Do Ask, Do Tell series, which was basically a campaign series that designed materials such as posters and brochures that organizations could display in their waiting rooms, exam rooms, etc., in order to let patients know that a particular organization provided welcoming and inclusive care for everyone. I don't have any relationships with the industry to disclose. So our objectives for today, we're going to define various terms that clinicians should be familiar with in order to provide LGBTQ-friendly healthcare. We're going to identify barriers to healthcare for these individuals. We're going to describe some important components of taking a sexual history. And then lastly, we're going to discuss preventative care guidelines, including STD screening for this special patient population. If we have time at the end, I'll also go over some special considerations for transgender patients. So statistically speaking, it's been estimated that among adolescents ages 18 to 19, just under 8% of females and under 3% of males do identify as homosexual or bisexual. They've looked at survey data from population-based samples of certain state and urban school districts and estimate that about 1.8% of high school students also identify as transgender. So the 2015 Youth Risk Behavior Survey, so it's part of the Centers for Disease Control and Prevention's Youth Risk Behavior Surveillance System. And so state and local agencies will actually conduct these surveys that look at two parts of sexual orientation. So they look at sexual identity, so how these high school students identify themselves, and also what are the sex of their sexual contacts. And that's where this data came from. So in 2015, they estimated that about 321,000 high school students were gay or lesbian, about 964,000 identified as bisexual, 514,000 were not sure of their sexual identity, and then as far as sexual contacts, 273,000 had sexual contact with only the same sex, and then 739,000 had sexual contact with both sexes. And what they also saw was that lesbian, gay, bisexual students and those students who had had same-sex sexual contacts, basically they were as diverse as their straight peers. So they were of all races, ethnicities, they were geographical, diverse. So what this survey also showed was there was discordance between sexual identity and sex of their sexual contacts. So among those that had same-sex only or both-sex sexual contacts, 25% identified as straight and 13.6% were unsure of their sexual identity. And then for those who had had opposite-sex only contacts, 2.8% identified as gay, lesbian, or bisexual. And so as providers, we really cannot infer someone's sexual identity from their behavior. And we'll talk a little bit more about this in a minute. So let's define terms that we need to be aware of. So LGBTQ plus stands for lesbian, gay, bisexual, transgender, questioning, or queer, and then plus kind of includes everything else, pansexual and asexual being examples. Sex refers to biological markers and anatomic characteristics, including organs and genitalia, and we are assigned one of two sexes at birth, either male or female. Gender identity is a person's internal sense of being male, female, both, neither, or some other gender. And for most, their gender identity does correspond with their assigned sex at birth, and that's also known as cisgender. Transgender people, their gender identities don't correspond with their sex at birth. So some terms specific to the transgender population. So transition is going to refer to the process in time when someone goes from living as one gender to living as another gender. Those who are assigned a male sex at birth but identify as female can call themselves transgender women, trans women, or male to female persons. And then on the other side, those who are assigned a female sex at birth but then identify as male, those are transgender men, trans men, or female to male persons. And they may alter their physical appearance, often through hormonal therapy and surgery, in order to affirm their gender identity. Sexual orientation is how a person characterizes their physical, sexual, and emotional attraction to others, and there's actually 3 dimensions. So attraction and desire, so what gender someone is attracted to, behavior, so who they have sex with, and then identity, how they actually identify themselves. And again, we really cannot infer someone's identity from their behavior because there has been this discordance. A few sexual orientation terms. So lesbian is going to describe women who are emotionally and sexually attracted mostly to women. Gay describes men who are emotionally and sexually attracted mostly to men. Gay is also sometimes used to describe all people who have same-sex attractions. Bisexual describes people who are emotionally and sexually attracted to both men and women. And then heterosexual and straight describes people who are emotionally and sexually attracted mostly to people of the opposite gender. MSN are men who have sex with men, and WSW are women who have sex with women. They're often used in the clinical setting, but not really by the patients themselves. Pansexual describes a fluid sexual attraction to people of any sex or gender, and then asexual is a person who does not feel sexual attraction. And then queer is an umbrella term that can include the entire LGBT community, and then it also includes those who fit outside social norms of sexual identity and gender expression. And it really emphasizes fluid and experience-based identities and attractions. Gender expression is how a person demonstrates their gender through behavior, mannerisms, speech patterns, dress, and hairstyles. And as you can see, that looks, there's a ton of different ways that people express their gender. This is the genderbread person. This is actually, I believe, version 2. They're on the 4th version now, but the 4th version is much longer and wouldn't fit on a slide. But basically, it's just a visual aid that kind of explains identity, expression, biological sex, and sexual orientation in a graphic form. So if you hear me refer to sexual minority throughout my talk, so that is just individuals who identify as gay, lesbian, or bisexual, or who are attracted to or have sexual contact with people of the same gender. Questioning, that's the process of exploring and discovering someone's sexual orientation, gender identity, or gender expression. Gender nonconforming is the state of one's physical appearance or behaviors that don't align with societal expectations of their gender. And that could be like a feminine boy, a masculine girl, a tomboy. And then gender non-binary, those are individuals who don't identify their gender as a man or woman, and they can also use the term gender queer, agender, bigender, gender creative. There's a ton of different terms now. And then finally, gender minority are those individuals whose gender identity or expression is different from their sex that was assigned at birth. Now, gender dysphoria is distress that's experienced by individuals whose gender identity does not correspond with their assigned sex at birth. It can manifest itself as clinically significant distress or impairment in social, occupational, or other important areas of functioning. And that's really the important part, and that's part of the DSM criteria as well. They have to have that clinically significant distress or impairment. Gender dysphoria can emerge basically at any time. If it remains through adolescence, it's usually going to persist long term. But many children that have gender dysphoria become homosexual or bisexual, but not necessarily transgender by adolescence or adulthood. And then not all transgender people experience gender dysphoria. So in children, they can express a wish to be of the other sex. They may be unhappy about their physical sex characteristics and functions. They may prefer those toys and games that are commonly associated with the other sex. They may prefer to play with other sex peers. It is relatively common for them to have coexisting disorders such as anxiety and depression. Also, the prevalence of autism spectrum disorder does appear to be higher in clinically referred gender dysphoric children than in the general population, and we see that with adolescents as well, and that's definitely an area for more study. Gender dysphoria in children usually disappears before or early in puberty for most children, and then if they have more extreme nonconformity, then that is usually associated with a persistence into adolescence and then adulthood. This is the DSM-5 criteria. I'm not gonna go through all of them, but basically you have to have the incongruence between identity and gender or assigned sex at birth for over 6 months, and then they have to have, so with children, they have to actually have 6 of these, plus the distress or impairment that I was talking about. In adolescents, so if they do have gender dysphoria that has persisted, it may intensify. They may develop body aversion as they're developing their secondary sex characteristics. Also, many adolescents and adults who present with gender dysphoria do not report non-conforming behaviors as children. And then many adolescents will have a strong wish for hormones and surgery in order to affirm their gender identity. They do also have more rates of anxiety and depression. They can also have higher rates of externalizing disorders like oppositional defiant disorder, and again, we see that there's a higher prevalence of the autism spectrum disorders. And these are the DSM-5 criteria for adolescents. So a little less strict for adolescents. They only need 2 plus that distress. So now we're gonna move on to health disparities in this patient population. So many patients are happy and thrive during their adolescent years, but as a group, they are more likely to experience difficulties. So LGBT youth are 2 to 3 times more likely to attempt suicide. They're more likely to be homeless, they're at increased risk of bullying, they're more likely to use alcohol, and they're more likely to engage in risky sex, which includes unprotected sex, multiple sex partners, as well as having sex under the influence of any alcohol or drugs. And so this is just a graphic from the CDC that shows how at-risk sexual minority youth are. So again, as opposed to their heterosexual counterparts, higher risk of being bullied, higher risk of using illicit drugs, misusing prescription opioids, higher risk of being forced to have sex, much higher risk of seriously considering suicide, and then you can see just 63% felt sad or hopeless. So really huge numbers. So some patient barriers to medical care. A lot of these patients are economically disadvantaged. They may lack insurance coverage, social isolation, fear of discrimination, fear of judgment is a big component. Negative past experiences, whether that be in healthcare or just with the community that they live in general, and then false beliefs about healthcare screenings, and we'll talk a little bit more about that as well. In terms of providers may lack training and competence. They may have experienced overt or covert harassment by provider or support staff. Lack of support and training by clinic, especially for transgender people using appropriate pronouns, preferred names. All of that is a really big deal to these patients and can really make them feel uncomfortable. And then lack of LGBT sensitive intake forms. So to create a welcoming clinic environment, we can participate in provider referral programs through organizations such as the Gay and Lesbian Medical Association, gayhealth.com, advertising in LGBT media, having universal gender inclusive restrooms, which is huge, and we'll actually talk a little bit more about that later as well. We can post LGBT friendly symbols, stickers, signs, and I'll show you some examples of those in a bit. We can display brochures and educational materials that specifically address health concerns for these patients. We can disseminate a non-discrimination statement, display posters from nonprofit organizations like LGBTQ or HIV organizations, and then we can customize patient intake forms to be more inclusive. And so this is actually an example of a non-discrimination policy from the AMA, so that we could, something that we could just disseminate to patients or have at registration, something that shows that we don't discriminate at all based on any of these. So for intake and history forms, those are a really good way to obtain information from patients, and if they are available prior to the appointment, then it can really make patients much more comfortable answering them at home as opposed to in the waiting room surrounded by a ton of people. Make sure to include statements that ensure confidentiality as well. And then it also allows us, if we have those beforehand, to be more comfortable, be more prepared. We can know their preferred name, their preferred pronouns, and use them appropriately. And so these are some examples of just some questions. So, as far as sexual orientation, we have, everything, other, not sure, don't know, and then, all of the options, relationship status, instead of just single, married, or divorced, domestic partnership or partnered, involved with multiple partners, other. So again, just really inclusive, giving a lot of options. And then for gender, instead of just the typical male and female, we have, transgender. Also, there's also a spot for other. And I'm actually looking at designing intake forms that are more inclusive for our Providence Clinic, since we do see a high rate of that population out at our Providence Clinic. And so I'm actually working on that now for our clinic out there. Epic has also made it a lot easier with using the preferred name. It's easier to put in a preferred name. It is the one thing that Epic doesn't do well is for transgender patients, because their sex often still is male or female. In the notes, the incorrect pronouns just automatically get used. However, there is, I believe Dr. Beal was telling me, you can mark not sure, and then it'll use like they and their instead of he or she. And so it is a lot better. We didn't have that option with the old Epic. And so for transgender people, it's really important to establish a good rapport, use their preferred name, use the pronouns that they prefer, and then also, their genitalia, that is a very sensitive subject for them, and a lot of them may have different names that we've never heard of that they call their body parts. You ask them what they call it, use those names. They may not call their breast. And so use that name and those terms, especially when you're talking about it or having to examine it. All right, so we're gonna move on to taking a sexual history. So sexual health histories are really important, probably more in medicine than pediatrics, but it is often skipped unless the patient has a complaint that's relating to sex or STDs. I feel like in pediatrics we do a better job of talking to patients about at least their sexual activity and getting a basic history. But there are several reasons some physicians may avoid it. It can be uncomfortable. They may have a fear of offending patients. They may just have inadequate training. And then they may worry about also identifying problems that they don't really know how to treat. So it's so important because in the United States, adolescents are disproportionately affected by STDs and unintended pregnancy. So they have the highest rates of STIs of any age group. And then although there has been a downward trend, adolescents in the US still have higher rates of unintended pregnancies compared with other developed countries. And it's part of preventative health care, so we should be doing it. The AAP recommends taking a sexual history at least annually, and then because they're all preventative health outcomes with potentially serious permanent sequelae, preventative care really is how we should be attacking it. So this was from the 2017 Youth Risk Behavior Survey, and you can see that especially in this population, they had higher rates of ever having sex, having 4 or more lifetime partners. They were more likely to be currently active. They were less likely to use condoms, and then they were, so compared to heterosexuals, those who weren't sure of their sexual identity, and the LGBT patients, they less likely used effective hormonal birth control and used both condom and birth control. And this is basically just that information in graphic form. So keys to taking a sexual history. First and foremost, you want to let your patients know that taking a sexual history is part of routine care. You do it for all of your patients. You want to make sure that they don't feel like you're singling them out. You want to avoid assumptions. You want to be non-judgmental and supportive. You want to use gender-neutral language. Be specific, especially for teens, as specific as possible, and then assure their confidentiality. So Washington State actually had interviews with about 24 adolescents that were getting care in one of their public health clinics, and they just asked about their prior experiences, talking to providers about sex, and so from their perspective, they did feel uncomfortable or embarrassed. They did feel off guard or offended when an unfamiliar doctor asked about sexual health, so the importance of developing rapport with patients. They did worry that their confidentiality would be violated despite confidentiality statements, mainly to their parents. There was also a fear of being judged. They appreciated providers who did acknowledge their concerns, and then they also saw providers as the gateway for services and supplies, such as condoms. And so really, most of them did prefer non-judgmental, straightforward providers that seemed to normalize all their sexual health and sexual health issues. This is one of the algorithms for conducting a sexual history. There are many out there. So first you want to set the stage. Again, let them know that this is part of your normal yearly health care and exam. Explain that all patients get asked these questions, and then you can begin with 3 screening questions. Have you been sexually active in the past year? Do you have sex with men, women, or both? And how many people have you had sex with in the past year? And then there are other questions you can kind of go down depending on how they answer. The CDC has also developed the 5 Ps. So partners, practices, protection from STDs, past history of STDs, and pregnancy plans. They are pretty detailed, and I can't say that I ask every single one of them, but honestly, for patients especially, so for all patients now, I mean, really, when I start, I talk to all my patients about this at least once a year, or if it's their first visit, I say, so part of your health care is your sexual health, and so I do need to talk to you about that. And ask them, are you currently sexually active? For the kids, I often say, are you having sex with anyone, or have you had sex with anyone recently? Because we know that kids, if it's not yesterday, then the answer may be no. And then, if they say no, when's the last time you had sex? And then I'll say, are your partners men, women, or both? I just had a patient the other day. You could tell when I asked that question, he immediately got really comfortable because I didn't make assumptions, and actually told me that he had a male partner that he had been with for 33 years. But, I mean, you could visibly see how relaxed he was when he saw that it was part of my normal routine and I had no judgment, which I really appreciated and he really appreciated. So again, asking about partners, how many partners, what are the sex of partners, and then asking about possible if their partners were having other partners, and then asking about any type of violence or abuse from partners, because these individuals are also at higher risk of partner violence. Practices, what kinds of sex are they having? This can especially be important for men who have sex with men, kind of affects our STI screening guidelines. Again, asking about anal sex, did they receive or give anal sex? Asking about oral sex. Again, if they've given oral sex, that also affects STI screening. asking about drug use or transactional sex, so giving money or some other goods for sex, because that all places someone at higher risk, and then your screenings change. Asking about condoms. So asking a teenager if they use condoms, most of them are going to say yes. You really have to be specific. Do you use condoms every single time? Have you always used condoms every single time? And most of them, the answer is going to be no. And then that's an opportunity for education and counseling. And then asking about past history of STDs. And then any pregnancy plans. Asking about information. If they want birth control, again, don't assume just because they identify as lesbian, gay, that they don't have sex with people of the opposite gender, because they very well may. I can't speak this morning. And then you do need to offer those patients pregnancy prevention. And then asking them if they have any concerns about their sexual function or sexual health. Asking if they have any concerns about masturbation, and really just normalizing the whole sexual health. All right, so switching gears a little bit, we're going to start talking about prevention and screening guidelines. So for tobacco and drug use, the USPSTF actually does recommend that we ask all adults, and remember adults 18 and older, so some of you will be seeing adults, ask about tobacco use, advise them to stop, and then provide any behavioral interventions or pharmacotherapy for cessation to those who use tobacco, and that is a grade A recommendation. Also, the USPSTF does recommend that we screen for illicit drug use in adults. And then we provide them services for that, and that's a grade B recommendation. In 2011, the AAP did come out with a policy statement that recommended screening adolescents as well for any type of tobacco and drug use. And then going back to that 2015 Youth Risk Behavior Survey, lesbian, gay, and bisexual students, or those unsure of their identity, had higher rates of cigarette smoking, alcohol use, marijuana use, hallucinogen use, heroin use, methamphetamine use, and use of prescription drugs that were not prescribed by a physician. And this is from the 2017 Youth Risk Behavior Survey, so we can see that, again, this patient population more likely to use illicit drugs, more likely to inject drugs, and then misuse opioid prescriptions. And again, that's basically just that in graphic form. So cervical cancer screening applies to all individuals with a cervix, which does include transgender men. I feel like this is something, as pediatricians, you won't be dealing with as much unless there are special circumstances, but definitely for med-peds residents here, that is something that we have to keep in mind. And then, so it is a grade A recommendation to screen everyone 21 to 65 at least every 3 years. For those 30 to 65, then we can lengthen the screening interval, but that's not something you need to know for pediatrics. Now, for the exception is those with HIV should be screened twice within the first year after their diagnosis, and then if it's normal, annually thereafter. I did look on ACOG. I found that they do want you to screen even if they're less than 21 if they have HIV, but I couldn't find a specific age. And so that I'll have to look more into. But definitely if you have an 18, 19-year-old and they have HIV, then they should start getting their cervical cancer screening earlier. Now, in terms of mental health, this is really a huge topic for this patient population. And so, you know, LGBTQ youth and transgender youth felt depressed most or all of the time compared to their non-LGBTQ counterparts. And so in one study from 2016, 2017, so 28% of LGBTQ with 40% of the transgender youth compared to 12% of non-LGBTQ. And then with the 2015 Youth Risk Behavior Survey, about 60% reported being so sad or hopeless that they basically stopped doing things that they usually did. This patient population, they're 2 times more likely to feel suicidal, over 4 times as likely to attempt suicide compared to their heterosexual peers. And then transgender youth are more likely to experience depression. According to the study in 2015, the risk was nearly 4 times. And then a third of transgender youth from that same study had actually seriously considered suicide. 1 in 5 had made a suicide attempt. The Trevor Project also, which if you haven't heard of it, really advocates for LGBTQ mental health especially. So they actually did conduct this large national survey in 2019 to look at mental health in this patient population. 39% had seriously considered attempting suicide in the last year. More than half of transgender and non-binary youth had considered it. And then 71% reported feeling sad or hopeless for at least 2 weeks during the past year. So again, huge numbers. And you know, these issues can be a result of lifelong stigma, harassment, discrimination, and they really do get chronic stress, depression, anxiety, and other mental health problems. What they've seen in some studies as well is basic issues like restroom access can also have a really profound effect on transgender youth. So there was this 2016 study that showed that those students who were denied access to gender-appropriate facilities on their college campuses were 45% more likely to attempt suicide. Primary care settings can offer a safe environment for these individuals to bring up their concerns. And so routine primary care visits should include screening for these mental health conditions. We should also be asking if they do have a history of anxiety and depression, what their past treatments were, if they have a history of suicide or self-injuring behaviors. If they have substance use, we should be screening for all of that so that we can provide the appropriate interventions. Protective factors, strong family bonds are really huge. So those who had supportive families do have a higher level of self-esteem and overall health. If LGBTQ youth had less supportive families, then they were more than three times more likely to consider an attempt suicide. And then transgender children as well. If they had families who affirmed their gender identity, then they were as psychologically healthy as their non-transgender peers. Also, safe schools, support from caring adults, including healthcare providers, having a more inclusive community, all of those factors are protective. So this is basically just showing data from 2017 that look at mental health in this patient population. So again, feeling sad or hopeless, higher rates of considering suicide and making a suicide plan, attempting suicide, and higher rates of being injured in a suicide attempt. And again, that's just all of that information in graphic form. So intimate partner violence, so we really should be screening women of childbearing age for intimate partner violence and providing or referring those who screen positive to support services. It's estimated that 50,000 to 100,000 women are battered by a same-sex partner each year in the U.S. And so the CDC actually conducted a national intimate partner and sexual violence survey, and 44% of lesbians and 61% of bisexual women experienced rape, physical violence, and stalking, compared to 35% of heterosexual women. 26% of gay men and 37% of bisexual men experienced rape, physical violence, and stalking, compared to 29% of heterosexual men. And then 46% of bisexual women were raped, compared to 17% of heterosexual women and 13% of lesbians. And then 40% of gay men and 47% of bisexual men experienced sexual violence other than rape, compared to 21% of heterosexual men. The 2015 U.S. Transgender Survey also found that 47% of transgender people are sexually assaulted at some point in their lifetime. And so again, really huge numbers that we should be screening for. This is the percentage of high school students from the 2017 Youth Risk Behavior Survey that experienced sexual dating violence or physical dating violence. So sexual dating violence being forced to do sexual things like kissing, touching, having intercourse when they didn't want to by someone they were dating, and physical violence being physically hurt, like being hit, slammed into something, injured with an object or weapon. And so, as you can see, much higher in that group. And that's just a table on victimization of these individuals. And so you can see more likely to be threatened or injured at school, more likely to not go to school because they were concerned for their safety, high rates of being bullied online, being bullied at school, high rates of being forced to have sex, and then again experience the dating violence. And that's just graphs of that. So we're going to move on to STI screening. So for chlamydia and gonorrhea, the USPSTF recommends screening those 24 and younger and in older women who are at increased risk. So increased risk is if they have a new sex partner, more than one sex partner, a sex partner that has concurrent partners, a sex partner that has an STI, inconsistent condom use on those who are not in a mutually monogamous relationship, if they've had a previous or coexisting infection, and if they exchange sex for money or drugs. Urine testing is the preferred method in transgender persons. There is no evidence to suggest routine screening for chlamydia in transgender women who have undergone vaginoplasty. The screening interval of 3 months is recommended for those at high risk. Screening interval is at least annually for MSM at the sites of contact, regardless of condom use. And so again, that's why I was saying it's really important to know what type of sex they've engaged in so you know how to screen, because I actually had a patient that I saw with a medicine resident. We did actually screen him. We did urine, did a rectal swab, did a throat swab, and his rectal swab was positive for chlamydia while the rest were negative. Had we only gotten urine, we would have missed the diagnosis. And so it's really important to take that sexual history. And then for HIV persons, they should actually be screened at their first evaluation and then have at least annual screening thereafter. So Region 7, Shreveport. So basically, I'll just go through the data from 2018. So you can see, we have come down over the years, but we did have the third highest number of diagnoses and diagnosis rate in Louisiana. 71% of those diagnosed were 24 and under. And so our patient population is going to be those that need the screening the most. For gonorrhea in Region 7, again, we had the third highest number of diagnoses and diagnosis rates in Louisiana. And again, 61% of cases were 24 and under. So the Louisiana Department of Health actually comes up with these posters yearly, and they're really great resources to have, and I wish I knew about them before, and I'm definitely looking for the ones that are kind of come out in 2020. But basically they give, they're really nice, very colorful posters. They give the statistics, and I think they could be really great, useful resources to have in our clinics. And so I just wanted to include those. I'll have some more examples. For syphilis, the USPSTF recommends screening in those at increased risk. And that includes men who have sex with men, those with HIV, if they have a history of incarceration or a history of commercial sex work. And unfortunately, we do see those patients in the PEDS population. And then transgender men and women are susceptible, and therefore, really the recommendation is now do a physical exam and do appropriate testing when you feel it's clinically indicated for transgender patients. For pregnant women, we do screen at the first prenatal visit, early in the third trimester, and then at delivery if they are high risk. Men who have sex with men, we need to screen at least annually if they are sexually active, and for HIV, they need screening at their initial evaluation and then annually thereafter. So Region 7, in 2018, we had the 4th highest number of diagnoses in Louisiana. 34% were in 24 and under. The biggest group was those 25 to 34. Some of you may still be seeing 25-year-olds. And this is some more of those fact sheets. And so this one actually talks about syphilis during pregnancy and congenital syphilis. And then this is about primary and secondary syphilis. For trichomonas, the CDC recommends considering to screen women that have or that are more likely to have it, such as those who are seeking care at an STD clinic, correctional facilities, those who do have multiple sex partners, transactional sex, and if there's a high prevalence in the community. And they do recommend screening HIV women who are sexually active at their initial evaluation and then annually. They don't have any recommendations for HIV-infected men. For herpes, USPSTF recommends against routine serologic screening for general HSV infections. Transgender men and women are susceptible, and so a physical exam and testing, if there's a clinical indication, is appropriate. And then you can do type-specific testing for those who present with an STD evaluation if they have multiple sex partners, HIV infection, or they are men who have sex with men. For hepatitis B, so below is a list of all those who are at high risk, including men who have sex with men and those who are HIV positive. And then we also recommend it for pregnant women, infants who are born Hep B surface antigen positive mothers, and household contacts or sexual partners who have HBV. Hepatitis C, we just screen in those who are at high risk. And again, similar risk factors: incarceration, intranasal drug use is one, getting an unregulated tattoo, which we have seen in the pediatric population. I actually heard a story about a kid not too long ago brought a tattoo gun to school, and they confiscated it, and he was like charging $100 for tattoos, doing them at recess. And then all transgender persons who inject soft tissue fillers or share syringes should also be screened. HIV is the big one, so we recommend universal screening for all patients 13 to 64 at least once, and then if they're older or younger than that age and they have risk factors, then we should screen them as well. Repeat screening is basically based on risk assessment. Men who have sex with men should be screened annually if sexually active, and if the patient or partner has had more than one sex partner since the most recent test. And so obviously risk factors include having sex with an HIV-positive partner, more than one sex partner, injecting drugs and sharing needles, transactional sex, and having other STDs, TB, or hepatitis. So in the U.S., the estimated, between 2005 and 2008, so the number of cases actually increased among 15 and 19-year-olds and 20 to 24-year-olds. It is among the top 10 leading causes of death in the 20 to 24-year-old patient population. There's approximately 1.1 million people living with HIV, and about 14% of them don't know that they are infected. Those numbers have ranged from 14 to 20%. What the CDC said was about 14%. And then young people were most likely to be unaware of their infection, and about 54.6% of 13 and 24-year-olds who were living with HIV were unaware, so more than half. And those do count for a large amount of the new infections that are occurring. Estimated that 38,000 new infections occur each year. In 2017, the South made up 52% of new diagnoses in the U.S. And again, the patient most affected is going to be gay and bisexual men, and they accounted for 69% of all HIV diagnoses in the U.S. and 86% of those among male. This is just some graphic representation of the new HIV infections. So this shows by race and group, so whether they're heterosexual, bisexual, gay. And so we can see African American gay and bisexual men are at the greatest risk. And these are just the total diagnosis, and so we can see African Americans do make up the largest part. This is from 2017, so Louisiana, that nice darker blue. Again, new diagnoses, male-to-male sex contact was the highest risk, and then, by race and ethnicity, African Americans were at the greatest risk. And that's kind of just showing what we talked about before. Black male-to-male sexual contact is the most affected population. And then this is new data from the CDC from 2018, and again, the South, which includes Louisiana, 52% of new diagnoses. In Louisiana, 1 in 4 diagnoses occurs among those 13 to 24. Black youth are more affected than other youth. Among trans women diagnosed in Louisiana, 1 in 3 were youth. I'm not going to go into the specific numbers, but transgender women diagnosed, 86% of them were also Black. And then 3 in 4 transgender people living with HIV in Louisiana live in the BR and New Orleans public health regions. In Region 7, so we had the 4th highest number of new HIV diagnosis, 5th highest HIV diagnosis rate in Louisiana. 26% were 24 and under for new diagnoses, and 47% 25 to 34. So these are some more of those flyers. So advertising HIV Testing Day, which was June 27th last year, and giving some statistics. Youth HIV/AIDS Awareness Day, which I will be honest, I didn't even know was a thing. So that was information on the 2019 posters. Again, HIV in transgender people, specifically HIV/AIDS and AIDS in Louisiana. Posters for gay and bisexual men and their awareness day. Hispanic. So they really do, in women and girls, and Blacks and African American, they really do make posters that target all of these populations. We know that transgender patients do have higher rates than the general population. Their death rates are 30 times higher due to AIDS, and about 1/4 of those women, transgender women, are living with HIV. Infection rates in transgender men are just not well documented, but because they often want to belong in gay male communities, they do engage in high-risk behavior, including HIV-positive circles. Documentation of female-to-female HIV transmission is controversial, but we know that they can become infected through other risky behaviors. Prophylaxis, condoms, consistent condom use decreases acquisition by 80%. They can be problematic in the transgender population. Also, PrEP and PEP can be utilized as well. So PrEP, that it is currently a grade A recommendation from the USPSTF for clinicians to offer PrEP with effective antiretroviral therapy to those at high risk of HIV acquisition, which of course include men who have sex with men and are sexually active and either have a serodiscordant partner, inconsistently use condoms, and have anal sex, or have other STIs within the past 6 months. Heterosexually active women and men with one of those risk factors, and for STI they specify syphilis or gonorrhea. And then those who inject drugs and either share drug injection equipment or have risk of sexual acquisition of HIV. And so the recommended is daily Truvada. It can reduce the risk of getting HIV by about 99% when taken daily. And it can also reduce the risk of getting HIV from injection drug use by at least 74%. And then we need to exclude current infection prior to giving it. And there is no contraindication between hormone therapy and Truvada for transgender patients. This is just a summary, a table summarizing PrEP guidelines. NPEP, or non-occupational post-exposure prophylaxis, that should be started as soon as possible to be effective, always within 72 hours of a possible exposure. And then it's a 28-day course of a 3-drug antiviral regimen. And there are now a few regimens that are approved. And that's just some of the considerations and kind of an algorithm for what you should do if you think a person needs NPEP. So hepatitis A, universal immunization for all sexually active gay and bisexual men. I won't spend a whole lot of time on this because usually as pediatricians we are pretty good about getting our kids vaccinated. Hepatitis B as well, universal recommendation for those sexually active gay and bisexual men. HPV, we know it's recommended for everyone through age 26. Meningococcal, so we're now doing the Menactra and Bexsero are the ones we have here. And then pneumococcal, just be aware, remember HIV or immunosuppressed patients, they need the PCV13 when they're less than 19, or I'm sorry, after they're 19, and then they'll also need the PPSV23 because they are immunocompromised. And then flu is recommended for everybody, 6 months and older. Really the only thing I want to say about the transgender patients, mental health assessment, again, mental health issues are key, and if you think a patient has gender dysphoria, they really should see a mental health provider who has extensive training and is comfortable in diagnosing gender dysphoria. And so they need to be trained in adolescent and child psychopathology. They need to also be able to diagnose gender dysphoria and incongruence and distinguish those from other similar disorders. They need to be able to undertake or refer out to appropriate treatment. And they need to assess their understanding mental health and social conditions that could be impacted by gender-affirming therapy. So affirmation therapy is usually with hormones or surgery, and for some it is needed to alleviate their gender dysphoria. Others only need one option, some need neither. And so some individuals with psychotherapy can actually integrate their trans or cross-gender feelings into the gender role they were assigned at birth. The current standard of care is to allow each transgender person to seek those interventions that they desire. And again, that can include anything from voice and communication therapy, hair removal, breast binding or padding, genital tucking, penile prosthesis, padding of the hips and buttocks, or changes in their name and gender marker. And then hormone therapy allows the acquisition of their secondary sex characteristics that are more aligned with their gender identity. And they're not recommended for prepubertal, or gender dysphoric, or gender incongruent persons. So now no referral letter is needed. Most endocrinologists are doing this now. For adults, if they're 18 and older, I know Dr. Beal is also doing hormonal therapy. I probably will be in the future as well. So feminizing hormone therapy, we won't go into too much, but basically it causes breast development, redistribution of hair, reduces muscle mass, reduces body hair, arrests possible scalp hair loss. Some of the risks of estrogen therapy, thrombosis, weight gain, increased triglycerides, elevated blood pressure, decreased glucose tolerance, infertility, gallbladder disease. Right now there's no studies that for sure say that there's a link between hormonal therapy and development of any cancers. And so if you do see young adults who are on these, common side effects, migraines, mood swing, hot flashes, weight gain. And again, if they smoke, they're at higher risk of embolism, and you can consider aspirin. Feminizing therapy, let's see here. We'll skip over that. Masculinizing therapy, again, suppress female secondary sex characteristics. You get facial hair, virilizing changes in the voice, increased muscle mass, increased body hair. And then they may see an increased libido, clitoral growth, vaginal dryness, and cessation of menses. There is a risk of polycythemia. And with any of the with any of the hormone therapies, if they have a sex hormone sensitive cancer, that is obviously an absolute contraindication to using it. And for testosterone, lowers HDL, elevates triglycerides, increased homocysteine, hepatotoxicity, polycythemia, increased risk of sleep apnea, insulin resistance, and infertility. These are the various surgical interventions. And then these are just, so the the Fenway Institute actually has a lot of guidelines, and GLMA also has guidelines for if your patients are on hormone therapy, what type of lab monitoring they'll need. These are a few different resources for providers, so GLMA, UCSF, Fenway Institute, which is where a lot of my information came from, and then WPATH. And then these are all the AAP publications that are related to sexual and reproductive health care that can actually be found on the AAP website. And those are my references. Any questions?